Hello, and thank you for taking the time to watch this training video on a new process for EMS bedside report on trauma patients. Handoff, as we all know, is the transferring of patient care from one caregiver to the next caregiver. No matter who the care providers are, EMS to ED staff, nurse to nurse, or physician to physician, the handoff has frequently been identified as a high-risk activity that carries the potential for loss of critical information. There are 16 key pre-hospital elements that have been identified as essential elements in helping predict and/or affect the overall patient outcome. Therefore, these elements are essential to be included in the EMS report to the receiving clinician when they are applicable. Also, as you will note on this next slide, many of these elements also correspond with trauma activation criteria. The data points listed here are the 16 key elements identified in the literature. Presence of prehospital hypotension, any single blood pressure less than 90 systolic should always be included in the radio and bedside report. The Glasgow Coma Score, the patient age, all vital signs including end-tidal CO2 value, pulse rate, respiratory rate, oxygen saturation, quantity of blood loss in the field, death of an occupant in the same compartment or same vehicle, mechanism of injury, intrusion into the compartment that the patient was located, extended extrication times, estimated crash speed, the anatomic location of injury or injuries, pre-existing disease, and pre-hospital intubation. As you will note, however, not every element will be applicable to every trauma patient, but should be included in patient report when applicable. A study was conducted in 2009 that looked at these 16 data elements. The focus of the study was to determine how often these important elements, when applicable, were transmitted or given in the verbal report, and how often they were or were not received or documented by the receiving clinicians. The handoff from EMS was reviewed on a video recording to determine which elements were transmitted or verbalized in the handoff. Then the patient's chart was reviewed for which elements were documented or received. A total of 96 handovers were ultimately included in the final study. The results of this study showed that overall there were 580 elements, or 55%, that were left out or not given in the handoff. 473 elements, or 45%, were transmitted or verbalized in the handoff, and 329 elements, or 70%, were received or documented in the chart. As you can see from this study, there was definitely room for improvement. Communication from one clinician to the next clinician is vital. Information loss or gaps can lead to a longer length of stay and can lead to a delay in timely and appropriate clinical care. Handoff has been widely documented as a high-risk medical legal event in the inpatient hospital setting. One identified method to assist in prevention of information loss during handoff of patient care is the use of a standardized or structured handoff format. The VISS mnemonic is a widely identified standard handoff for the EMS provider to the trauma team. M for mechanism of injury, I for injuries sustained and identified, S, signs and symptoms in the field, and T for treatment provided in the field. For this new process at the University of Tennessee Medical Center, we have added one twist consisting of an addition of V at the beginning. Thus, we are requesting that the most recent set of vital signs, including the GCS, be provided at the beginning of the verbal bedside report. Bedside report would always start, of course, with the patient name and age, and then flow directly by the VMIS mnemonic. A brief time for questions can be allowed at the end of report as well. Beginning on June 1st, 2016, EMS will have a 30-second dedicated timeout to give an uninterrupted report to the trauma team. The flow will be as follows. EMS enters the bay with the patient and stops at the foot of the bed for a brief breath sound assessment by the resident. The EMS cot will be moved parallel to the trauma bay stretcher. The patient will remain on the EMS cot. Timeout will be called by the resident at the head of the bed, and the VISS report will be given by EMS and questions answered. The patient is then moved to the trauma bay stretcher, and the trauma team initial assessment will continue. EMS will give any further pertinent details to the physician and/or nurse scribes. As with any new process, there are always exceptions. If the patient is in extremis or has an imminent need identified, examples being immediate intubation required or CPR in progress, the patient will be moved directly to the trauma stretcher, and EMS report will occur simultaneous to the trauma team assessment and/or to the scribes. Now you will see a video simulation of this new process.
Nurse assistants needed to room 12, please. Nurse assistants to room 12.
Okay, let's hold for breath sounds, please. I have equal breath sounds bilaterally.
We get EMS report nice and loud.
All right, guys, this is a 24-year-old female, Jane Doe. She is a plasma trial patient. Vital signs on scene were 53 systolic, a max heart rate of 135. Currently 118 over 60, heart rate is 113. She's setting 100% with the assisted ventilations and a good end tidal right around 35. She was involved in a rear-end type collision. She was the driver of a vehicle that rear-ended another vehicle. It reported high speeds. There was airbag deployment, long-term entrapment that required an approximate 30-minute extrication. Her injuries, as you can see, she has significant lacerations to the forehead. There's pretty significant bruising from the xiphoid down to the umbilicus. She has an open right knee and obvious deformity to that right leg, which is externally rotated outwardly. Signs and symptoms: she was unresponsive for EMS on scene. They reported that she was initially apneic and not moving. However, she responded pretty well with fluid resuscitation and assisted ventilations with the BVM in the car. As far as treatment is concerned, we did elect to RSI her in the field. She's received a total of 30 of etomidate, 10 of Norcuron, and 6 of Versed throughout the duration of the flight. She's also had a glucose of 132.
How much IV fluid she gets pre-hospital?
She's received, this is her second liter now. She's had a total of 1,800, and both units of plasma have already infused.
EMS on your count.
1, 2, 3.
The use of standardized communication is vital for efficient and thorough handoff. The VISS mnemonic will be used, and a dedicated timeout will be provided for EMS to give report to the trauma team, with exceptions of a patient requiring immediate life-saving measures beginning June the 1st, 2016. In addition, to assist in implementing this new process, there will be posters with the VISS mnemonic posted at the head of the bed in each trauma bay, and a pocket card with information will be provided to EMS providers in the region. Thank you to the following team members at our organization for their participation in this video, and thank you to all pre-hospital providers in this region for all you do in the care for our trauma patients.